World Diabetes Day. I would like to hand over to Professor Dr. Abu Kumar Mukherjee sir, who happens to be not only an emeritus and eminent professor of diabetology in India, but also the chairman and co-founder of our organization. Over to you, sir. If you please start on your brief discussion about diabetes and World Diabetes Day.
Good evening, everybody. My sincere thanks and gratitude to our overseas guest speaker, Professor Caroline Diacon, who is going to talk about the pleiotropic effects of DPP-4 inhibitors. It's important that we are celebrating the World Diabetes Day. We know the significance or the theme of the World Diabetes Day this year, education for progress tomorrow. So that will be a very important issue as propounded by International Diabetic Federation as well as World Health Organization, that we have to educate the healthcare personnel and effectively the patients and their caregivers all over in a very, very comprehensive fashion as well as in a holistic manner. We need to emphasize upon the different aspects of education quite often, and we need to know that the significance of the World Diabetes Day is to make everybody aware about the sinister situation of diabetes, mainly in the middle income and the low income countries. And we now know that the people suffering from diabetes are increasing enormously. And as propounded by the International Diabetic Federation, that by 2030, it will reach 583 million populations. And it's important that this is the most important cause of cardiovascular death, as well as the different organ dysfunction pertaining to kidney, nerves, eyes, and not only the heart, but the blood vessels as a whole, so that the complications need to be avoided. Diabetes is to be diagnosed as early as possible, as an annual program of checkup for every adult or any opportunity by the caregivers. So education to protect tomorrow is the theme this year. As we know, the awareness is being conducted since 21, this is 22 and 23 as well. And without wasting any further time, I feel everybody knows the theme, everybody knows how to comprehensively deliver the product to the patients as well as other healthcare professionals all over the country. And I sincerely welcome our guest speaker from Carolina, Professor Dr. Carolina Diacon, who is the Faculty of Health Sciences, Copenhagen, Denmark. And her topic is pleiotropic effects of DPP-4 inhibitors. Madam, please.
Thank you very much for the kind introduction, and let me also thank Professor Chowdhury and the organisers for their kind invitation for me to join this meeting. It's a great pleasure.
Thank you.
So, pleiotropic effects of the DPP-4 inhibitors. So just by way of introduction, reminding us that with DPP-4 inhibitors, they've got the action of the DPP-4 enzyme, and thereby they increase levels of the incretin hormones, so GLP-1, GIP, but possibly also other as yet unidentified substrates. And when we're looking at anti-diabetic effects, we're primarily focusing on the effects of the incretin hormones working via effects on the alpha cell and the beta cell in the pancreas to regulate glucose homeostasis. But then we do have the potential for other, what I've called here, non-glucose effects, which could be mediated potentially by incretin hormones, but as I mentioned, possibly other substrates could be contributing to these effects. And when we're looking at these, we're talking about potential effects on the kidney, on the cardiovascular system, the nervous system, possibly other anti-inflammatory effects, and maybe even other ones that we're not yet aware of. Let me start with the beta cell. And when we're talking about incretin hormones, we really tend to focus very much on the beta cell and the effects on insulin secretion. And this is an early study looking at the effects of DPP-4 inhibition in patients with type 2 diabetes, given a meal. And we're looking at here the glucose curves, and you can see the DPP-4 inhibitor, as we now know and expect, having a nice effect to lower blood glucose levels. But somewhat surprisingly, on first glance, when you look at the insulin levels, we don't appear to have any dramatic effect. But I think it's important to remember when we're talking about insulin levels, they're also related to the glucose levels. So normally, if we lower glucose levels, we would expect the insulin levels to fall. But what we can see here is DPP-4 inhibition is maintaining those insulin levels despite the fall in glucose. So we're still seeing an insulinotropic effect, which is what you can see here when we're looking at the insulinogenic index. Quite clearly, we're having a significant beneficial effect of DPP-4 inhibition. Now, this is working via various mechanisms to improve beta cell function. So here we're looking at an example showing on HOMA beta. Here is sitagliptin giving an improvement in HOMA beta score. We're seeing some benefit of metformin, but in this study, when you combine DPP-4 inhibition together with metformin, then we're getting this additive effect to improve beta cell function. And another way of looking at beta cell function is to look at the efficiency of processing proinsulin into insulin. And as we produce more insulin, the ratio declines. And again, we can see quite nicely the effect of DPP-4 inhibition together with metformin, giving a greater effect to regulate insulin and improve beta cell function. So these are the general effects on the beta cell. Now, I mentioned we tend to be quite beta cell centric, and very often the effects on the alpha cell are overlooked. These can actually be very important. So here is a very recent meta-analysis looking at DPP-4 inhibition effect on glucagon levels compared to placebo here and to other oral antidiabetic agents. So insulin secretagogues, the sulfonylureas, metoclopramide, you can see a clear beneficial effect favoring DPP-4. Also against the placebo, we're seeing significant reductions in glucagon levels. We compare against non-insulin secretagogues, so metformin, the alpha-glucosidase inhibitors, pioglitazone, or the SGLT2 inhibitors. Again, the DPP-4 inhibition is reducing glucagon levels so that the combined effect is a significant reduction in favor of DPP-4 inhibition. And I think it's worth pointing out that the incretin-based therapies, so that's the DPP-4 inhibitors and the GLP-1 analogs, are the only therapies at the moment that we have that are addressing the hypersecretion of glucagon that we see in patients with type 2 diabetes. So why is this relevant? Well, we can see it in this study. This is a study done in patients with type 1 diabetes, no residual beta cell function, so no endogenous insulin production for a DPP-4 inhibitor to enhance. But when we give a DPP-4 inhibitor, we're seeing an improvement in the postprandial glucose excursions. And when we look at glucagon levels, here we can see a significant reduction in postprandial glucagon levels, and thereby reducing endogenous glucose production, leading to this reduction in glucose. Here is another study showing that addition of a DPP-4 inhibitor prior to intensification of insulin therapy is improving glycemic control. Here with sitagliptin versus placebo, we can see reductions in fasting plasma glucose levels, and this is associated with a reduction in the daily insulin dose required. And again, we can attribute this in part to the reduction in glucagon levels. So why is this? Well, DPP-4 inhibition is improving the way the alpha cell senses and responds to glucose. So we're looking here at 2 meal challenges separated by a period with a hypoglycemic clamp. And what we can quite clearly see is in the periods when we have raised blood glucose levels, we're seeing a suppression of the postprandial glucagon secretion. But in the period during the hypoglycemic clamp, when blood glucose levels are falling below normal fasting levels, we're seeing no impairment of the counter-regulatory responses of glucagon, or indeed any of the other counter-regulatory hormones. And it's these preserved counter-regulatory responses, together with the glucose-dependent effect on insulin. So once glucose levels fall below fasting, we no longer stimulate insulin, and helping to explain the hypoglycemia we see with DPP-4 inhibitors. And the suppression of postprandial glucagon and therefore hepatic glucose production is helping to explain why DPP-4 inhibitors are still effective in patients with long-standing diabetes and thereby with reduced beta cell function. So we shouldn't underestimate the effect of the DPP-4 inhibition on the alpha cell. Now, I put this slide up because when we're talking about one of the newer agents that are becoming more commonly used, the SGLT2 inhibitors, these actually raise glucagon levels. So here we can see saxagliptin, the DPP-4 inhibitor, associated with a reduction in glucagon, whereas we're seeing a significant increase with, in this case, with dapagliflozin. And this is reversed by DPP-4 inhibition. So does this have any beneficial effect? Well, in this particular study, the changes in insulin and glucose, but surprisingly somewhat, the changes in glucagon area, not the changes in the glucagon area, were correlated to the change in HbA1c. So the significance of the SGLT2-induced increases in glucagon remains to be clarified, but there is this nice association that when we use the combination between a DPP-4 inhibitor and the SGLT2 inhibitor, that we do reverse this hypersecretion of glucagon. So that was a brief overview of the pancreatic effects of DPP-4 inhibitors. So what about some of these other potential non-glucose related effects? So let's look first of all at the cardiovascular effects. And we have a number of preclinical studies that have suggested that DPP-4 inhibition could potentially have beneficial cardiovascular effects. So these are studies that have been done in animals or in isolated organs or cell preparations, suggesting that DPP-4 inhibitors can be associated with cardioprotection, with improvements in myocardial performance, in improvements of endothelial function, and also by decreasing some of the cardiovascular risk factors such as blood pressure, dyslipidemia, hyperglycemia, weight, and so on. So how does this actually pan out in the clinic? Well, when we're looking at small to medium-sized clinical studies, then we do see some evidence that we may see beneficial effects. So this was an early meta-analysis looking at some of the clinical trials, DPP-4 inhibitors against comparators. And here you can see that there was a reduction in major adverse cardiovascular events. There was a reduction in acute myocardial infarction, and there was some suggestion that overall mortality was reduced in this meta-analysis. We should also, though, bear in mind that these were, in these clinical trials, the phase 3 trials, small numbers of events, with the phase 3 trials usually excluding patients with cardiovascular disease. We also have data from some of the experimental medicine studies. This is a small studies in patients type 2 diabetes and coronary artery disease, looking after a dopamine stress test and showing that DPP-4 inhibition improved myocardial performance. You can see here after this peak stress period, the association of sitagliptin here was leading to an improvement in the ejection fraction. And there are several other small studies that would also showing similar kinds of beneficial cardiovascular effects. However, when we look at the large prospective cardiovascular safety outcome trials that we now have with most of the DPP-4 inhibitors, and here data from 4 of them with saxagliptin, alogliptin, sitagliptin, linagliptin, these studies suggest that DPP-4 inhibitors, they're safe, they don't increase cardiovascular adverse events, but neither do they improve them. Those were against placebo, the Carolina study, comparing DPP-4 inhibitions against a sulfonylurea. again showing no apparent cardiovascular events, so they weren't adverse effects, but neither did we see any beneficial effects. And there was no trend towards benefit in any of the individual components or in heart failure outcomes or in all-cause mortality. What there was, though, was a clear effect on hypoglycemia, that this was reduced independently of the actual sulfonylurea dose Carolina study. For those of you who might be interested in looking to see the various ways in which DPP-4 inhibitors compare with sulfonylureas, I wrote this review with Harold Lebowitz that was published in Diabetes of Easy Metabolism, comparing the two different classes of agents. So there's been some debate over whether hospitalization for heart failure might be an adverse effect of the DPP-4 inhibitor class. And this was brought out primarily because of this trend we saw here in the Sabatini trial, but there was no evidence for an increase in hospitalization for heart failure in Examine or in TECOS. And the Carmelina study also confirming that this effect on hospitalization for heart failure is not a class effect. And indeed, this was also seen in the Carolina study, no increase in hospitalization for heart rate with linagliptin here compared to glimepiride. So just to summarize these potential cardiovascular effects, the cardiovascular safety trials with 4 different DPP-4 inhibitors have confirmed their cardiovascular safety. They don't increase cardiovascular risk, but neither do they reduce it. The reason for the increased risk of heart failure hospitalization for saxagliptin is still unknown. It's not a class effect, but it might be related specifically to the saxagliptin, either the parent molecule or its metabolite, or it could be simply due to chance. We have some clinical data to support possible cardiovascular effects in these pooled safety analyses, meta-analyses of phase 3 trials, which tended to be in healthier patients, not at high risk, and these have suggested a potential risk reduction. And we have some small mechanistic clinical studies also suggesting potential cardiovascular protective effects. We should also remember that cardiovascular safety trials did involve patients all at high cardiovascular risk or with established cardiovascular disease, where the patients were well treated for comorbidities, they had relatively good renal function. The trials assessed time to a cardiovascular event, and we have no information yet really on how the patient fared after their event, whether there was any potential benefit there. And we may need a longer exposure time to see any potential cardiovascular effects of DPP-4 inhibitors. So what about renal effects? And again, just some of the preclinical studies which do suggest that there may be potential renoprotective effects. In these preclinical studies, we've seen effects to improve diuresis, to increase natriuresis. We've seen some renal hemodynamic effects to moderately increase glomerular filtration rate and reduce hyperfiltration. We've seen morphological effects on the kidney in terms of glomerular sclerosis or fibrosis. And we've also seen improvements in renal risk factors. However, when we're looking at small to medium-sized clinical trials, it's been no real evidence for any effect on glomerular filtration rates. So here is one study, insulin-naive patients with type 2 diabetes, EGF around 83 mils per minute at baseline. And you can see here DPP-4 inhibition in yellow. Here's also data with one of the GLP-1 analogues with liraglutide, but showing no effect compared to placebo on eGFR over the 12-week of the study. And here's another study with patients with type 2 diabetes. These were patients with moderate or severe renal impairment. And again, over the course of the study, you can see neither in the moderate nor the severe renal impairments was there any significant difference between placebo treatment or vildagliptin in terms of the change in eGFR over the course of the study. Again, this is backed up with some of the data from the cardiovascular outcome trials. Here is data from TECOS showing a fairly stable eGFR over the 48-month period of the study. And similarly, data from the Sabatini trial showing no evidence for any change in eGFR with DPP4 inhibition. Now, when it comes to albuminuria, we have somewhat conflicting results. The Marlena study, these were done in patients with persistent albuminuria on stable treatment with ACE inhibitors or angiotensin receptor blockers. And although there seemed to be some small trend here for a reduction in the urine to albumin creatinine ratio, overall, when it's placebo adjusted, there was no significant effect in this particular study. Whereas in another study in patients with moderate to severe renal impairment, you can see eGFR around 34 mils per minute in this study. Here we did see a somewhat significant improvement in in the creatinine, albumin to creatinine ratio. And these effects were more marked in the patients with macroalbuminuria. Now here, when we're looking at the cardiovascular outcome data, we do see some evidence that there may be an improvement in albuminuria. So data from the Sabatini trial, around 16% of patients here with eGFR of less than 60 mils per minute. And what we're seeing here is there was a significant reduction in the number of patients with a deterioration in albuminuria. And conversely, we saw an increase in the number of patients showing an improvement in albuminuria over the course of the Sabatini trial. And similar data was seen in a subset of patients from the DECODING study, just under 10% of patients with eGFR of less than 50, but showing a significant reduction in the albumin creatinine ratio over the 48-month period that was looked at in the DECODING study. And large observational study has also shown that sitagliptin does seem to be associated with a reduction in the UACR from a baseline of around 140 milligrams per gram of creatinine. DPP4 inhibition has also been shown to reduce albuminuria progression in the Carmelina study. Now, this study differed from the other cardiovascular outcome studies in that it was more focused on patients with renal disease. You can see here around 62% of the patients with an eGFR of less than 60 mils per minute. And over the course of the study, we did see a significant improvement, 14% reduction in worsening of albuminuria. However, when we looked at the hard renal outpoints, so the kidney composite outcome of first sustained end-stage renal disease, death due to renal failure, or a sustained decrease of over 40% in eGFR, there was no significant effect. So despite the improvement in albuminuria, there was no significant effect on the hard renal outcomes. So to summarize these, the DPP4 inhibitors, we shouldn't forget this, they're safe and effective in patients with impaired renal function. They can be used at all stages of renal impairment, dose adjustment for some of them, but also including patients on end-stage renal disease on dialysis with no evidence that any DPP4 inhibitor adversely affects renal function. They can also be used when other medications are contraindicated or not suitable, and they don't increase the risk of hypoglycemia. We have small mechanistic studies which do support possible renal effects. Generally, we're seeing beneficial effects on albuminuria. There's also a natriuretic effect. I didn't show you data on this, and this seems to be via inhibition of distal tubular sodium reabsorption, but we see no apparent effect on renal hemodynamics. In the cardiovascular safety trials, in patients with established cardiovascular disease or at high risk for cardiovascular disease, is confirming the renal safety of the DPP4 inhibitors. They don't increase renal adverse events, but nor do they reduce them. They don't adversely affect eGFR, but they do appear to reduce the progression of albuminuria. So what about any potential neural effects? Do we have any data here? So again, preclinical studies have suggested that there may be some beneficial effects. There's been seen and reported neuroprotection in terms of reduced peripheral nerve generation or apoptosis of neurons, improved functional outcome after stroke has been shown in preclinical studies. There's improvement in peripheral nerve function. Some morphological effects have been identified, and CNS function in terms of cognitive function has been shown to be improved in some of these preclinical studies. Now we have data from a retrospective longitudinal study in patients treated with DPP-4 inhibitors and metformin compared to a sulfonylurea and metformin combination, and these were followed over 2 years, and this was in patients with mild cognitive impairment. Notably, similar improvements in glycemic control in both arms of the studies, but looking at these various measures of cognitive function, cognitive impairment was significantly improved. There was improvements in visual attention or task switching with the DPP-4 inhibitor. Working memory was improved, and verbal fluency was also improved with the DPP-4 inhibitor, whereas these parameters were largely unchanged in the sulfonylurea arm. And here's another study. Again, it's a population-based, it's a retrospective and observational study. New users of DPP-4 and sulfonylurea compared, looking at all-cause dementia or Alzheimer's disease, and you can see significant reductions in the progression, so hazard ratios of 0.66 or 0.64 here, suggesting that DPP-4 inhibitor may reduce the risk of dementia compared to sulfonylureas in these elderly patients with type 2 diabetes. But we have another small prospective randomized control studies. So these are clearly studies specifically addressing in a prospective manner cognitive performance, and this showed no change in anything compared with a DPP-4 inhibitor or with a GLP-1 analog. And here's another study. This was a sub-study of the large Carolina study, the outcome study with linagliptin, with the primary cognitive outcome being the occurrence of accelerated cognitive decline at the end of follow-up. This was a relatively long study of 6 years, but as you can see here, no significant effect on cognitive decline in this particular study. I mentioned potential effects in terms of the immune system. So what about autoimmune disorders? Again, we're not looking at randomized control style types of studies. These are population-based studies, but suggesting there may be an association with a lower risk of autoimmune disease. So potentially an effect here of DPP-4 inhibitors on rheumatoid arthritis, other autoimmune disease, and here's the composite of autoimmune diseases in the study, showing a benefit and an effect of the DPP-4 inhibitors to potentially lower this risk. And here's another population-based study, again, this time in Korea, but also seeing a similar trend, effects in terms of rheumatoid arthritis, inflammatory bowel disease, other autoimmune diseases, and again, this composite outcome. And then the final one I just want to go through with you is effects in fatty liver disease. This is an area where we're seeing increasing interest, an increasingly problematic area now. And small studies have suggested that DPP-4 inhibitor does improve glycemic control in patients with fatty liver disease. We can see in this particular study, we're comparing liraglutide, sitagliptin against placebo, showing improvements in these patients in HbA1c. And here's a second study, again, liraglutide, sitagliptin. At this time, the comparator is insulin, showing similar improvements in HbA1c levels. But the effects on intrahepatic lipids are somewhat conflicting. So in this first study, neither liraglutide nor sitagliptin had any significant different effect or differential effect compared to placebo. Whereas in a second study against the insulin comparators, both of the incretin-based therapies did improve intrahepatic lipids. And in another group of patients, this time patients with NASH, again, we're seeing improvements in glycemic control in NASH patients, but the effects on liver histology, again, are conflicting. So liver histology itself, no beneficial effects, no difference between the study here with sitagliptin compared to placebo, whereas we did see no effect also on the NAFLD activity score. The other study here, though, no effects on the liver histology, but there was an improvement in the NAFLD activity score. So conflicting data, and we don't really understand the reasons why we're seeing these disparate effects. So DPP-4 inhibitors improve glycemic control in patients with type 2 diabetes with NAFLD or NASH, but further studies are needed to resolve whether or not they actually affect the progression of fatty liver disease. And this is in part complicated because it's actually quite difficult. We have no easy surrogate marker for measuring these other than taking biopsies. So to summarize the conclusions, glycemic effects of DPP-4 inhibition involve both insulin and glucagon. Potential non-glycemic effects of DPP-4 inhibition remain to be clarified. Beneficial effects have been seen in some, and they're mostly small studies, but have not been confirmed in the large cardiovascular outcome studies. We can ask ourselves why they were not confirmed in the cardiovascular outcome studies when the small studies specifically designed to answer some of these questions did see a benefit. So it could be that it takes longer to see any non-glucose effects. And just for an example here, any potential renoprotective effect could be secondary to morphological changes, and these may take more time. An important difference between the cardiovascular outcome studies and these smaller studies where we saw the non-glycemic effects are that the cardiovascular outcome studies involve patients with cardiovascular disease and or with risk factors, and mostly they had relatively good renal function. And the non-glycemic effect may be more apparent in the more general type 2 diabetic patient, which is typically included in the smaller studies and the phase 3 studies. In the cardiovascular outcome studies, the glycemic differences between the arms were generally small. That's what they were designed to do. They were designed to be equally poised in terms of glycemic efficacy. And there's a possibility that the non-glycemic effects could be related to improvements in glucose homeostasis. In other words, they might be glucose dependent in the same way that the effects on insulin and glucagon are also glucose dependent. So my overall take-home message is that DPP-4 inhibitors, they're simple to use, they're well-tolerated drugs which add on well to pre-existing metformin therapy. They have beneficial effects on both beta cell function and alpha cell function. And we really need to remember this effect on alpha cell function because this accounts for around about half of the overall effect in terms of glucose reduction. So we have insulin secretion being maintained despite the reductions in glucose levels. So no absolute increased levels, we're maintaining them despite the fall in glucose levels. The suppression of glucagon and thereby hepatic glucose production also contributing to improved glycemic control. These alpha cell effects explain why DPP-4 inhibitors are still efficacious in patients with impaired beta cell function. And the alpha cell effects explain why additional efficacy is seen when DPP-4 inhibitors are combined with insulin and potentially may contribute to the beneficial effects of adding DPP-4 inhibitors to the SGLT2 inhibitors. DPP-4 inhibition has no adverse cardiovascular or renal effects, or indeed any adverse effects on the nervous system or any of the other areas that have been examined. The DPP-4 inhibitors can be used safely in patients with established cardiovascular or renal disease, but the potential non-glycemic effects still remain to be fully clarified. So with that, I will just end and thank you very much for your attention.
Thank you very much. That was a wonderful disposition on DPP-4 inhibitors, and who better than you to talk on this subject. And we do remember that possibly, was it early or mid 1990s, that your lab has been instrumental in studying the metabolic stability of GLP-1, and from which actually grew the concept of DPP-4 inhibitors. So can I ask you, because we won't find a better person to ask these very basic questions. We all do talk about and do understand the important role of DPP-4 inhibitors in acting on the alpha cells. But are there many or significant number of GLP-1 or incretin receptors on alpha cells?
Yeah, I mean, this is a good question because when we're looking at GLP-1, then there is not strong evidence for GLP-1 receptors on the alpha cell. There's quite clearly GLP-1 receptors on the beta cell, and GLP-1 has direct effects on beta cells to increase insulin. But in the alpha cell, if you look in an isolated alpha cell and you give GLP-1, there may be a tiny few receptors there, but if anything, that isn't associated with an increase in glucagon. And this is where it can be problematic looking in the isolated system as opposed to the whole system. And when we're looking at the whole pancreas, the whole endocrine pancreas, then it is indirect suppression of glucagon because there are GLP-1 receptors on the delta cells. And the DPP-4 inhibitor is protecting GLP-1. GLP-1 is then working on the delta cell to increase somatostatin production, and its indirect effects of somatostatin, which then inhibit or suppress glucagon. In terms of the other incretin, GIP, then yes, we have seen GIP receptors on the alpha cell, and GIP actually stimulates glucagon secretion once blood glucose levels fall. And this is being put forward as a potential possible additional mechanism to explain the low hypoglycemia risk we see with DPP-4 inhibitors, that GIP may be involved in enhancing the counter-regulatory response to hypoglycemia. So GLP-1 effects on the alpha cell are indirect, mediated through somatostatin, whereas GIP effects at low glucose level actually enhance glucagon.
Right. The other sort of question, very related question would be, if you are increasing the level of somatostatin, would it not also suppress the insulin?
The somatostatin does suppress insulin, but we're talking about very local paracrine effects. And the delta cells tend to be they're not the typical like round cell. They tend to be cells with projections which can come forward from the delta cell and make contact with the neighboring glucagon cells, the alpha cells. So we're talking at very local effect, paracrine effects. And this is also enhanced by the blood flow going through the endocrine pancreas, which tends to flow from the beta cells towards the alpha cells, and similarly with the delta cells. So in that case, when we're seeing the effects of somatostatin on the alpha cell, we're less likely to see it on the delta cell because of this local paracrine interaction and the way in which the blood circulates within the endocrine pancreas or within the islets.
Right. And you did mention about the autoimmune effects. Could you kindly just come back on it and maybe elaborate a little bit on it? What would be the potential mechanism?
Yeah, I mean, it's a good question, and a lot of this still remains unclarified. Part of it could be due to anti-inflammatory effects mediated by GLP-1. Whether or not there are GLP-1 receptors on immune cells themselves, some studies have said that they have identified the GLP-1 receptor, whereas others haven't. And it's very difficult because the antibodies used to identify the receptors or the GLP-1 receptors are not always completely specific. So at the moment, we don't know really whether these are direct effects mediated, for example, by GLP-1 on the immune cells, or whether they could be indirect effects because of improvements in glycemic control or other risk factors which are altered in an indirect manner. So it's not really clear to say precisely how they work at the moment. And as I said, the data is also conflicting. It's been shown in some small studies, but not in others.
Right. So we have a question from the audience, whether you would like to take it or not. Which oral antidiabetic drug reduces HbA1c rapidly Would you like to take that?
Yeah, I mean, in terms of the oral agents, in terms of very rapid ones, I would say it would be the sulfonylureas or the meticlinides that have a very rapid onset, because you're seeing direct effects on insulin secretion. We see effect with the other agents. They tend to come on still fairly quickly, but not initially as rapid as the sulfonylureas.
Right, good. And once again, going back to the CVOTs not showing a significant benefit, but the potential being shown in smaller studies or mechanistic studies. And you feel it's related to studying maybe more cardiovascularly affected population in the CVOTs? I thought that would be an easier way of uncovering any potential benefit, because the risk, if the risk is high, then you don't need a big study or a long-term study. You can see the effect relatively early. Whereas what you say is in relatively healthy individuals or less cardiovascularly affected individuals, possibly in small studies, some potential benefits have been seen with the DPP-4 inhibitors.
Yeah, I mean, it does seem paradoxical. I mean, I fully agree. You would expect if you're going to see a benefit, you would see it in patients at high risk. We should remember that a lot of these patients at high risk, they're already fairly well treated for their cardiovascular disease, whereas the less ill patients in the smaller studies were not really being treated, so giving you a potential to see a benefit if they're not already on other agents.
Right.
Sorry?
Yeah, sure. Yeah.
Yeah.
So,
and the other difference between the cardiovascular outcome trials is that we see very small differences in glycemic control, because the two arms were designed to have equal glucose levels. Whereas in some of these smaller studies, when they were treated with a DPP-4 inhibitor, you also got a glycemic reduction, which might be indirectly affecting some of the outcomes.
absolutely. So, I think we should once again thank you for your commitment and for your study in this area of the last 30 years or so, and which really gave birth to this wonderful class of molecules, which may now at this point of time be overshadowed, may be overshadowed to an extent by the SGLT2 inhibitors or the GLP-1 receptor analogs. But in terms of ease of use, they are amongst the best, almost placebo-like side effects in most individuals, and we don't need to bother about hypoglycemia, weight gain, and issues like that. And they indeed are a very important addition to our armamentarium in the management of type 2 diabetes. So thanks, Dr. Carolyn Deacon, once again for this wonderful oration on the occasion of World Diabetes Day 2022. Let's hope you continue to contribute actively in this field in the years to come, maybe through your scholars who are doing the PhD, and have a very good evening ahead. Thank you very much once again.
Thank you.
We shall move ahead with the next part of our program, but you are most welcome to remain with us, or you can take it easy. Thank you very much.
Thank you.
So we now go over to another very interesting part of this evening's program, and which is the quiz, which will be related to diabetes, I suppose. And our quiz master, our quiz lady is Dr. Sunitra Mondal, who is a brilliant endocrinologist and is a consultant at the Health World Hospital in Durgapur. So over to you, Sunitra. And you may explain the rules of the game to our participants.
I hope my slides are visible.
Yes, and you are audible.
Thank you so much, sir. And thanks to you and all my teachers over here for giving me this opportunity. Quiz is a very interesting part of any program, and also a very nice opportunity to learn and relearn and revise old concepts. So first I'll clear the rules of the game. So all participants, you will receive a link which will be sent by the tech team. And this is the same as the registration link which you have already received. So this is a purely online quiz. And once you click that link, which you have been sent, you will directly go to a Google form, which will show you the quiz questions. So in that Google form, you have to register by entering your email ID and name. This is compulsory, otherwise your scores will not be marked. Then what I'll do is I'll read out the questions one by one. And simultaneously, you can also see the same questions on your online quiz form. So you can see all the questions at a time on your quiz form, but I will suggest you see them one by one. So while I read, you see the same question on the form, because some of the figures in the form are sort of blurred and not very big. So once I'll show them on the screen, things will become more clear to you. And so after I read out the question, I will wait for 30 seconds after each question for you to contemplate and fill whatever you feel is the right answer for the corresponding question. So there are total 15 questions.
Sorry, Sunetra. So this is a multiple choice question?
Yes.
Okay, right.
Yes, sir. So there are 4 options for each question. So 15 questions. So a total of 60 marks. There is no negative marking. But once you have entered your option, you cannot change it. So think before you are ticking. And after all the questions are filled up, you have to submit it. So that should be latest within 60 seconds after I read out the last question. That is the 15th question. And of course, the last part is that you have to wait for the results. It will all be computerized results. So there is no question of any bias. And I'll then check my spreadsheet and announce the 3 highest scorers. And this is then the responsibility of the organizers to find them out and award them their prizes. So before I begin, can I ask whether all of you have received the registration link? And if that is working fine, tech team, please check out. Is there any issue?
Checking, ma'am. Just done.
Okay, so once anybody clicks the link, it is getting redirected to the quiz form.
Right, ma'am.
Okay. Thank you. So I'll just start with the questions. I'll put my stopwatch on and. Okay, so my first question. So this is a 23-year-old gentleman, HbA1c 8.2%. So the first figure shows one of his clinical findings. And the second figure shows his pedigree chart. So the proband, that is our gentleman, is marked by the black arrow. You'll also see the figures on your Google form. So my question is, this gentleman, say Mr. X, does not have a higher than average risk, for which of the following? Cardiac arrhythmias, myopathy, renal cysts, and pigmentary retinal dystrophy. Please notice it is X does not have a higher than average risk for which of these?
Sunetra, I hope this is, you started with the toughest question and things will become easier as we go down.
Yes, sir.
Okay. Very true.
Coming to my next question, 30 seconds over. So for continuous glucose monitoring in pregnancy with diabetes, what is the recommended target range for blood glucose for which the time in range is calculated as per all guidelines recommendations? So for continuous glucose monitoring, what is the target range for blood glucose for which the time in range is calculated in milligrams per deciliter? Is it 70 to 180, 95 to 120, 70 to 130, and 63 to 140?
Just one interruption, madam. If anybody is having any inconvenience in clicking the link, just note your registration link is the link. As we have seen that somebody has written in the chat box that they are not being able to open the link. Your normal registration link is the link. If you click there, you will see the questions are already there. It's visible to most of them, but if still somebody feels any problem, you can check the link in the chat box also. Thank you.
And unless and until you register with your email ID and name, the
Right.
options will not work. So.
Right.
So I move on to the next question. So this is a recent trial most of us have heard of, the SURPASS-2 trial. This was with tirzepatide. So my question is, what was the active comparator against which tirzepatide was compared? Semaglutide, long-acting exenatide, liraglutide, or it was a placebo-controlled trial? So there was no active comparator. Are there any more issues? I find there are many things in the chat box. Can anybody please check?
No, just they have sent the links twice.
Okay.
Others are right. It's visible on there.
So I move on to the next question. So which risk calculator for atherosclerotic cardiovascular disease includes a clause for the duration of diabetes? I repeat, which risk calculator for atherosclerotic cardiovascular disease includes a clause for the duration of diabetes? Duration of diabetes, not just diabetes. Is it ASCVD risk estimator plus? Is it the Framingham risk score? Is it the UK-PDS risk engine, or is the MESA CHD risk calculator? Please note, it has to be the duration of diabetes, not just the presence of diabetes.
Can I request all other analysts to kindly mute themselves?
Okay. So my next question is, all of the following can be used to differentiate between FCPD, that is fibrocalculous pancreatopathic diabetes, and alcoholic chronic pancreatitis, except, so which of these cannot be used to differentiate between these two? Predominantly large and intraductal calculi in FCPD versus small and scattered calculi in other chronic pancreatitis, more marked fibrosis of the pancreatic parenchyma in FCPD, a higher risk for macrovascular complications in FCPD, and a more rapid progression of the diabetes in FCPD. This is my 6th question, again a pictorial question. So this is a 22-year-old lady, HbA1c 9.1%. She was admitted with acute pancreatitis And as of now, she was requiring an insulin dose of around 150 units every day. So these are her three pictures. Figure 1 shows one of her clinical findings. Figure 2 shows her ultrasound findings. And figure 3 shows her retina. You will also find these pictures on your Google form, the quiz form. So this is a 22-year-old lady, HbA1c 9.1%, acute pancreatitis, requiring a pretty high dose of insulin every day. So my
And
question
are we looking? Sorry.
Yes, sir?
So are we looking at the ovaries, the ultrasound?
Yes, this is one of her ovaries.
Yeah.
So my question is, which is the syndrome that this lady is having? Rabson-Mendenhall syndrome, familial partial lipodystrophy, leprechaunism, or maturity onset diabetes of the young? I move on to the next question. So DIA-REM, this score is used to predict remission of type 2 diabetes following 6 months of supervised exercise program, remission of type 2 diabetes following a short course of metformin, remission of type 2 diabetes following bariatric surgery, and remission of diabetes following 3 months of intermittent fasting. So DIA-REM score is used to predict which of the following: remission of diabetes following a supervised exercise program, following a short course of metformin, following bariatric surgery, or following a period of intermittent fasting. I move on to the next question. So which of the following is not a method to improve the performance of FRAX for fracture prediction risk in type 2 diabetes? So FRAX is, as we know, is the fracture risk calculator. And for type 2 diabetes, all of these have been proposed as to improve the risk prediction, except one. So first is whether to tick the rheumatoid arthritis input to the FRAX calculator, whether we should reduce the femoral neck T-score input by 1 SD, whether we should use the trabecular bone score adjustment factor, or whether we should increase the age input of the patient by 10 years. So again, a pictorial question. So this is a 52-year-old lady, diabetic, CKD 5 non-dialysis. This is her clinical picture. She came with pain in her lower limbs, and this is her MRI picture. So my question is, what is the diagnosis? Is it diabetic amyotrophy, It is diabetic myonecrosis, necrotizing fasciitis, or DVT with compartment syndrome. Moving to the next question. Identify this imaging modality in diabetes. Is it optical coherence tomography? Is this fundus photography? Is this corneal confocal microscopy? Or is this fundus fluorescent angiography? Next question. Mechanism of action of gabapentin. Selective serotonin reuptake inhibitor, calcium channel modulator, serotonin and noradrenaline reuptake inhibitor, selective norepinephrine reuptake inhibitor. Mechanism of action of gabapentin. The next question. The International Diabetes Federation IDF criteria for diagnosing metabolic syndrome includes all of the following except, so which of the following is not a part of the criteria for diagnosis of metabolic syndrome? Triglycerides greater than or equals to 150 milligram per deciliter, a fasting blood glucose greater than or equals to 100, or a known history of diabetes mellitus, systolic blood pressure of more than or equals to 130, or diastolic blood pressure of more than or equals to 85, or on antihypertensives, and or an LDL cholesterol of more than or equals to 130. So which of the following is not a part of the criteria to diagnose metabolic syndrome? The next question. This may appear a bit complicated, but if we look at the figures properly and use a bit of logic, it becomes easy actually. So which of the following images for gastric emptying represents diabetic gastroparesis? Figure A, figure B, figure C, or it can be either B or C, or both B and C. In your Google form also, you can zoom the images and look at, have a closer look.
Would you explain what
This is
means 0
gastric.
hour, 2 hour, 4 hours? Yeah, I know.
Yes, sir. So for the participants, so it is the amount of food that is there in the stomach at 2 hours and at 4 hours after they have taken a meal.
So can the amount be more at 4 hours than at 2 hours?
Sorry, sir. I'm sorry. I was not right. Not the amount. It is the amount that is cleared. That is cleared from the stomach. Next question. Resolution of diabetic ketoacidosis is characterized by all of the following except a blood glucose of less than 200, absence of ketones in urine, serum bicarbonate greater than is equals to 18, and a venous pH of more than is equals to 7.3. So the last and the final question. So behind that question mark is hidden a set of trials, and have a close look at the figure which is posted here. So my question is, what is this question mark? So have a close look at the figure first, then I'll go to the options. Okay, so the options are on target, onwards, origin, amplitude O. So since this is the last question, I will wait for 60 seconds for you to complete all the questions and submit the form. Then please give me a couple of minutes while I look at the spreadsheet, and then I can announce the winners and also discuss the correct answers. So all of you, please submit your forms. I'll stop
Before,
sharing.
before Sunitra goes into the explanation of the answers, I would admit that I never knew that Sunitra could hold such fiery in-swingers and out-swingers, which would make most people difficult to bat on. I don't know whether the pitch is also unfavorable, but hope people have done well, and let's get the answers. And so this part of the charm in a quiz, of course, is to learn new things. So that's of course there. So we will await your explanations.
I hope all of you have submitted, because I'll now check at the spreadsheet. So after this, if anybody submits that, his or her scores will not be marked. I don't really find a lot of people participating. Maybe they did not like the quiz, or
No. I can say there are problems, some technical fault on our part. Actually, many could not be able to register their name, because those who are just attending in the social media on in Zoom, they couldn't. In the chat box also, they have explained that inability to participate because of some technical fault. So that's why
Well,
probably the participation.
yeah, okay. But anyway, let's learn the answers.
but the scores were, the highest score is much higher than what I had expected. It's pretty good actually. So this is from
What?
Dr. Sanchari Dhar. So
Oh,
the
great.
score is 40 out of 60. So she has got at least, she has got 10 questions correct.
Oh,
That's great actually. A clap
great.
for ma'am. Second highest is Dr. It's a tie between Dr. Snehashish Paul, 32 out of 60, and Dr. Kaushik Karmakar, also 32 out of 60. So all of them are postgraduate students. So indeed, great. I must admit, this is a great achievement. Actually, you know a lot. You know a lot more than what I did during my MD days. Okay, so applause for all of you. Others have also done pretty good. Actually, I cannot find a poor score. So should I go on to explain the answers?
Yes, you can just explain the answers. Then we have some thing to say.
Are my answer slides visible too?
Not yet.
Not yet.
Just a second. Is it visible now?
Yeah.
So this was my first question. 23-year-old gentleman with a hearing aid and a pedigree which shows that wherever the mother is affected, it has affected all her children. So this is purely a mitochondrial inheritance in a young gentleman with diabetes and a hearing aid. So this, and my question was, what does X does not have a higher than average risk for? Options were cardiac arrhythmias, myopathy, renal cysts, and pigmentary retinal dystrophy. So this was a case of maternally inherited diabetes with deafness. So the two most common mitochondrial diabetes would be this, along with MELAS, and it is a mitochondrial DNA point mutation. So after diabetes, the second most common clinical feature is sensorineural hearing loss. And other features would be pigmentary retinopathy, cardiomyopathy, focal segmental glomerulosclerosis, and myopathy. And there is a theoretical risk of lactic acidosis with metformin, for which this should be avoided in such patients. And so the correct answer was renal cysts, because this is found in HNF1 beta mutation modi. All of the other things can be found in mitochondrial diabetes. So my second question was target glucose range for time in range calculation when we are doing CGM in pregnancy with diabetes. So as per ADA guidelines, if we look at, so it has advised the usage of CGM in addition to self-monitoring of blood glucose, and that has been found to reduce macrosomia and neonatal hypoglycemia, mostly in pregnancy with type 1 diabetes. But it has particularly mentioned that CGM should not be used as a substitute to self-monitored blood glucose. Of course, we know for SMBG, the targets we use is a fasting less than 95 and a 2-hour post-meal glucose of less than 120. But if we look at the CGM, the target range for time in range calculation that they have recommended is 63 to 140. This is for type 1, type 2, as well as for gestational diabetes. So this was the right answer, 63 to 140. So coming to the third question, bit easy. So SURPASS-2 trial, we know that in this, the dual GIP-GLP-1 agonist tirzepatide. So the multiple doses of this drug was compared to semaglutide, weekly semaglutide injections. And it was found to be perform better than all 3 doses were found to perform better than semaglutide in terms of change in HbA1c, as well as in terms of change in reduction in body weight. So semaglutide was the right answer. Coming to my fourth question. So which atherosclerotic cardiovascular disease risk calculator has a clause for duration of diabetes and not just diabetes? So if we look at the risk calculators that I have mentioned in the option, so this is the ASCVD Risk Estimator Plus, which is recommended by ACC-AHA as well as by the American Diabetes Association. So they have a clause for history of diabetes, yes or no, but not for duration of diabetes. Then Framingham, it should not be used for those with diabetes. It clearly mentioned for those who do not have heart disease or diabetes. So this is the MESA. Again, this has a clause for diabetes, yes or no. But this is the UKPDS risk engine, in which multiple other factors of diabetes like diabetes duration, the HbA1c, the microalbumin, these are also taken into account. So this was the right answer. So coming to the fifth question. So between FCPD and alcoholic chronic pancreatitis, which of these factors cannot be used to differentiate these two? So if we look at the differences, so FCPD or tropical calcific pancreatitis, this occurs at a relatively younger age as compared to alcoholic chronic pancreatitis in relatively poorer subgroups of patients. Alcohol abuse may or may not be present, but of course, lesser prevalence as compared to alcoholic chronic pancreatitis. So usually mostly the calculi are very large and intraductal, and the fibrosis and the ductal dilatation is much more marked in FCPD as compared to alcoholic chronic pancreatitis. The risk of pancreatic cancer is also markedly increased in FCPD. The prevalence of diabetes as well as the time course of its evolution is much more rapid in FCPD. But as we know, these patients, both the subgroups of patients are usually lean, and the lipid parameters are not grossly deranged in FCPD, and therefore they do not really have a higher risk for macrovascular complications. So these are the photographs of FCPD, large intraductal calculi, so X-rays, radiographs, and these are small scattered calcifications mostly. So this was the right answer. They do not really have a higher risk for macrovascular complications. Coming to my sixth question. So this question I have basically copied because when I was in my first year of DM residentship, this was the question I marked wrong in the Endocrine Society of India quiz. So these were the pictures. So, and these were the options. And I thought it was surely some insulin resistance syndrome, but the answer was partial lipodystrophy. The clue to this is that this patient also has lipemia retinalis. And so severe hypertriglyceridemia is a feature of lipodystrophy, but not of insulin resistance syndrome. But acanthosis and polycystic ovaries and high insulin requirement, these can be seen in both. But so much of hypertriglyceridemia as to cause pancreatitis and also lipemia retinalis, this is not seen in insulin resistance syndrome. So Rabson-Mendenhall and leprechaunism, of course, leprechaunism is much more severe end of that spectrum. Even Rabson-Mendenhall is not the answer. The correct answer is familial partial lipodystrophy. And the other features that should increase the suspicion for lipodystrophy, all the patients do not come typically like what we expect them to be, with absence of body fat and typical that appearance habitus, not really. Prominent muscles and prominent veins can be a feature. They usually have severe acanthosis nigricans. Many, but not all of them, will have eruptive xanthoma. Some of them can have acromegaloid or progeroid premature aging-like appearance. Usually the insulin requirements is very high, to the tune of around more than 2 units per kg daily. So it's better to use U500 insulin in some of them. The hypertriglyceridemia can be very high. They can have NASH, they can have early onset cardiomyopathy, polycystic ovaries, of course. And so this was the key point, that severe hypertriglyceridemia is not a feature of insulin resistant syndromes. I focused on it because this is what I marked wrong and I learned by mistake. So this was the answer. Coming to my 7th question, so diarrhea score. So this is used just to mention here that diabetes cure is not possible, but diabetes remission has been defined over the past few years. And the definition that is used is an HbA1c of less than 6.5 or a fasting glucose of less than 126, at least for 3 months, while not on any therapy. And this can occur spontaneously in some patients, but usually it is following an intervention. This intervention could be strict calorie restriction. This could be through physical activity, through medical nutrition therapy, or through bariatric surgery. And the diarrhea score was first used by Still et al. In their retrospective review of around 700 patients with type 2 diabetes who underwent a Roux-en-Y bypass surgery. And up to 63% had complete or partial remission. And so a higher diarrhea score includes parameters like age, the HbA1c, requirement for insulin, requirement for other anti-diabetic drugs. And this has also been modified to the AD diarrhea score, which also includes the number of anti-diabetic drugs and the diabetes duration. So a higher score would mean a higher chance of remission following bariatric surgery. So this was the right answer. Coming to which is not a method to improve FRAX performance for fracture prediction risk in type 2 diabetes. So as we all know, type 2 diabetes does increase the risk for fragility or osteoporotic fractures, even though the BMT may not be very low. But the FRAX, which is the most commonly used fracture risk assessment tool, does not still have a column for input of diabetes mellitus as one of the factors. And therefore, several modifications have been proposed, like ticking this rheumatoid arthritis arm, decreasing the T-score, increasing the age of the patient during inputting, or using a trabecular bone score adjustment. So while all of these have been proposed, the crux was there was not much difference seen between these 4 methods when it comes to reclassification improvement in the risk calculation for major osteoporotic fracture risk. But the option B was not right, because this was the correct option, because it was to be reduced by 0.5 SD and not by 1. So T-score, it is in the range of 1 and 2. So if you reduce by 1 SD, that would mean quite a lot. So the right answer, the right option was to reduce it by 0.5. So this was the answer. So this one was, I guess, a relatively easy question. This was a patient in IPGMER. So as we can see, she has a swelling of her thighs. She had, in fact, affection of both her lower limbs, first her right, then her left. And the MRI shows a typical hyperintensity in her thigh muscles, and which was sort of heterogeneous. So the right answer was diabetic myonecrosis. This is more common in females, mostly in end-stage renal disease. Quadriceps are the most common group of muscles that are affected. CPK may or may not be high. MRI will show hyperintensity in T1 as well as T2 stirred images with a heterogeneous enhancement pattern. Recurrences are pretty common. Muscle biopsy would give the diagnosis, but this is not recommended for diabetic myonecrosis. Diabetic amyotrophy, the other potential option, could be seen even in well-controlled or recently diagnosed type 2 diabetes. They have more of muscle weakness and atrophy rather than pain. Autonomic neuropathy and significant weight loss are commonly seen in these patients. It is usually self-limited. Diagnosis is by electrodiagnostic studies. So this was the correct answer. So identify this imaging modality. So this is not a commonly used commonly used in laboratories and all. This is mostly an investigational tool, the corneal confocal microscopy. So this is a promising technique for early detection of diabetic neuropathy. This has been seen in type 2 as well as type 1 diabetes before changes in electrodiagnostic studies are evident, or before the patient even has symptoms of neuropathy. So reduced corneal nerve fiber density and nerve branch density have been seen. And so optical coherence tomography looks something like this. Even in black and white images, it would look like this. So this is a macular edema. It is usually used to detect macular changes. This is what a fundus photograph looks like. So with this, we can detect major diabetic retinopathy changes. And this is what a fundus fluorescent angiography would look like. This is used for retinal and choroidal circulation imaging for conditions like retinal artery occlusion, etc. So this was the right answer. Coming to mechanism of action of gabapentin. So this is a calcium channel modulator. SSRIs, as we all know, would be fluoxetine, escitalopram, things like that. And serotonin noradrenaline reuptake inhibitors, or SNRI, the commonly used agent in diabetic neuropathy is duloxetine. And selective norepinephrine reuptake inhibitor is tricyclic antidepressants like desipramine. So criteria for diagnostic metabolic syndrome includes all except. So if we look at the different diagnosis definitions of metabolic syndrome, be it WHO, be it NCP, be it IDF, none of them has a criteria for LDL, because as we know, LDL numerical value does not have quite of a relationship with insulin resistance or diabetes. If we had a parameter for qualitative LDL like small dells LDL, maybe things would have been different. But none of the criteria includes a clause for LDL. So this was the right answer. So this one, gastric emptying study by scintigraphy. If we look at the figures very closely, we don't need to know much about this technique. So this is where an egg meal level with a radioactive substance like technetium metastable 99 is given to the patient. So at time 0, the entire meal is within the stomach, and the normal ranges for gastric emptying is around 11 to 39% at 1 hour, 40 to 76% at 2 hours, and 84 to 98% at 4 hours. So if we look at figure B, at 4 hours, it is 81%, and at 2 hours, it is just 20%. So definitely there is a delay in the gastric emptying. So this is a slowed emptying. And if we look at figure C, just at 2 hours, it is around 98%. So it is accelerated gastric emptying. So figure B was the answer. There was slowed gastric emptying. So this represents diabetic gastroparesis. Of course, again, this is not something we do usually for all our patients to diagnose diabetic gastroparesis, but this is the test of confirmation. So resolution of diabetic ketoacidosis is characterized by all except. So the right answer was absence of ketones in urine. So we know urine ketostrips, the ketone bodies in urine can lag by 2 to 4 hours. Also, urine ketostrips do not detect beta hydroxybutyrate. So during DKA, that is in the acidotic milieu, the ratio of beta hydroxybutyrate to the other ketone body, that is acetoacetate, can be very high. But when there is correction of this acidosis, when there is resolution of the diabetic ketoacidosis, the ratio will start to reverse. So urine ketostrips may show even positive long after DKA has resolved, at least some time after DKA has resolved. And just to mention here that venous blood gas and arterial blood gas bicarbonate levels are not very different. So we can use venous blood gas very suitably to monitor DKA patients. We do not need to sample arterial blood repeatedly. So this was the right answer. Finally, the last question. So this was the group of trials with ICODEC. We know for the past, in the last year, results of many of these were published. So the right answer was onwards trial. So there have been 5 phase 3 trials with once weekly insulin. ICODEC, as we know, is the new once weekly insulin which has been compared to glargine, degludec. Similar rates of hypoglycemia has been seen in type 2, but in type 1, relatively higher rates of hypoglycemia were seen. And looking at the other, so this was the right answer, onwards trials. Looking at the other answers, so on target, this is the first trial that showed no benefit of combining an ARB with AC inhibitors. Rather, there could be an increased risk if we are giving dual RAS blockade. Origin trial was a CVOT for glargine, and Amplitude O was a CVOT for the weekly GLP-1 agonist, that is FP-glenatide, in those at high risk. So it was it showed benefit. So that's all for my questions from my side.
Thank you very much, Shuneta, for taking the trouble and also nicely explaining all the answers. That's the real value of being in a quiz, rather and beyond maybe the ability to win a prize or not. So let's hand over to the organizers, maybe Professor Pradeep Mitra, for the final words before we wind up.
Definitely, but before we wind up, we must thank Professor Caroline, for being present throughout the quiz session. Also, I'm seeing her present. So I'd like to have one or two comments on the our conduction of the quiz after her brilliant lecture. If she can give some insight or give some suggestions or comments on the quiz.
But this was actually much more clinically oriented, so may not be something that she would be the best person to, whatever.
Right, but how she feels about the conduction, not that fully scientific.
Yeah, the quiz for me as a basic scientist, the quiz was very medicinal, but I think I learned a few things as well. So I'm sure all of the participants learned a lot as well.
So I can confess, at least from my side, that if I am been exposed to give the exam on this quiz, I definitely I'll fail. I'll fail. It's a little bit tough for me, I think. And Professor Chaudhary rightly said that it started with the tougher questions, and then later on the relatively easier questions were there. Anyway, thank you again, ma'am, for being present throughout our sessions. Thank you. Before we end, actually, I can tell that the KNF, Kolkata Nurture Foundation, is working on it. We have done a lot of, this type of online webinars in the Corona period. And also we are doing many, health camps, more than 200 health camps we have organized by this in course of last 2.5 years or so. And we are also the UniHealth, which is organizing this quiz and the lecture, is the academic wing of the Kolkata Nurture Foundation. And we have Professor Subhankar Chaudhary, Professor Apurva Mukherjee. So we are hoping that in future also we'll be able to conduct such educational sessions, definitely in more close succession. And I think Shuneta would like to give another prize to third one, because there is a joint winner. So another prize may be given to.
Yes, sir, I will say, so the third person would be Dr. Ronit Bagh.
Ronit Bagh, okay. So
first is Dr. Sanchari Dhar. Second, joint tie second between Dr. Snehashish Paul and Dr. Kaushik Kormukar. And third would be Dr. Ronit Bagh.
And as you said rightly, also I didn't expect such a high score, in this type of questions. Professor Chaudhary also agreed with me. So it indicates the standard of the PGs going to, very competitive, and they're now starting very good. Thanks. Very good. Good going. So, Subhankar, over to Professor Chaudhary. Would you like to comment on anything?
No, I think we had a wonderful evening here. It's getting quite late into the evening. Of course,
Yeah.
maybe it's early evening or early evening or late afternoon for Professor Carolyn Deacon. It was wonderful learning experience, and we look forward to more such sessions. And I hope the prizes are reached to the ones who have won. So KNF or UniHealth will take the responsibility, I'm sure.
Absolutely.
Right, great, good. Thank you very much. So all things have to, good things also have to come to an end. So wishing you all a good evening, good night, and look to further academic sessions in future as well. Thank you very much. All of
Absolutely,
you.
sir. But before you wrap up, we must thank Dr. Sunatra Mondal very, very much, because she had taken a lot of industriousness to finish it up, go through the demo and everything. There might have been some lags or leaps from our end, loopholes from our end, which we would like to cover up in the next time. We have got few comments from the participants that the standards of questions were very high and they are interested to know these topics, as they do not commonly encounter these topics in the common diabetic forum discussions and all. Probably what we can see here are the participants who are being given the links, and those who are outside, that is on Zoom, other platforms, social media platforms, as we have shared internally, that they could not participate. We are really sorry for them, and we'll keep it in mind in the future attempts, and we'll take care of it. And thank you very, very much, Dr. Sunatra Mondal, for being with us.
Thank you so much.
Thank you. Thank you.
Thanks.